Hi everybody, I'm Dr. Talia Marcajani, and thanks for joining me live to talk about hormones. So this is a talk that's called All About Your Hormones. I was asked to write an article about hormonal health for an online publication, and it was a pretty difficult job because our hormones are so complicated. In order to make sense of the world, people create stories. This is a human tendency, is to create stories to explain the things we see in the world. It is one of our greatest gifts, but also our most fragile weakness. So for example, boy meets girl, they fall in love, they encounter difficulties that they eventually overcome, it brings them closer, they live happily ever after. The classic love story. Stress also has a classic love story. Our hormone cortisol, the stress hormone, is released when we're stressed out. It wreaks havoc on our body. Cortisol is bad. Lowering stress helps lower cortisol. However, when it comes to human hormones, telling stories in a linear narrative is actually impossible. It leaves way too much out and it oversimplifies these complicated networks of relationships. Hormones are these signaling molecules in our body. They're produced by endocrine glands, such as the adrenal glands or the brain and the ovaries. They travel through the bloodstream to impact the expression of our genes on distant tissues. And this impacts how our bodies function. So, for example, production of norepinephrine in the adrenal glands as a response to stress can make your heart race, your pupils dilate, your hands shake, and your senses to become hypervigilant. When a perceived threat or danger activates the release of this hormone, your entire body pulsates under its influence until that hormone is swept out of your body. Hormonal stories are hard to fit the desire for human narratives because their relationship with our genes, our bodily systems, our receptor binding sites, and each other makes their actions too complicated to be described linearly. Instead, they act like webs or tangled networks of intricate connections. When hormone levels rise in our body, beyond our delicate homeostatic balance, a phenomenon called resistance can occur. With resistance, cells reduce their responses to the hormones that interact with them. When telemarketers keep interrupting your dinner at 6 p.m., as an analogy, you eventually stop answering the phone. When certain hormones continue to call at the surface of cells that they're supposed to be acting on, and this stresses out our body's capacity to respond to these signals, our cells simply stop answering in order to re-regulate a state of balance. So many of us ask, what happens when I pull this thread here? What happens when I, take a birth control pill or replace my estrogen if my estrogen levels are low? What happens when I put all my focus onto cortisol and try and lower cortisol? When learning about one hormone that we've blamed all our woes on, but we tug one thread without considering the entire web of connections, and our actions can affect the entire system. We see this a lot with people who are vilifying insulin and explaining insulin as the sole reason why we gain weight, which simply isn't true. Our hormones exist in an ecosystem where everything hums and flows together as a unit. It's impossible to lay out explanations for their actions in a linear fashion. Hormone stories are more like a choose-your-own-adventure novel. So it's a hallway with many doors that snake down long corridors and then meet again and interconnect. And so you can imagine you go through a door marked estrogen and you're going to encounter serotonin, cortisol, progesterone, insulin, thyroid hormones, leptin, a satiating hormone, BDNF, which helps us make brain cells, dopamine, norepinephrine, and many others. Hormones are the conductors of your body's personal orchestra. They're composed of thousands of musicians, a complex musical score, highly trained arms, fingers, and mouths manipulating instruments, a million moving parts working together in harmony. The best we can do to understand this entire interplay is to slow down the action, take a snapshot of it, and try to understand why these symptoms are occurring in each individual that we're working with. Really common symptoms of hormone imbalances are important. So I'm going to talk about those now. So because hormones affect absolutely every system of the body, I'm always attuned to the possibility of imbalances in my patients. Now, hormonal imbalances are often not a root cause. If you think of our health as a tree and the branches are different symptoms that we're experiencing, and then the roots are, the cause of the symptoms on the branches, I think hormones are further down the trunk of the tree, but sometimes not the root cause, because we also wonder why are hormones out of balance in the first place. But it helps to look at hormones in terms of their symptom patterns, in my experience, rather than how any one hormone affects us in particular. So, for example, fatigue, low libido, restless sleep, depression, and anxiety, being restless at 2 to 4 a.m., a high-stress lifestyle, and brain fog may indicate some sort of cortisol or hypothalamic pituitary adrenal axis imbalance, stress hormone imbalance. PMS, and the more severe version of it, PMDD, irritability, fatigue, and low libido, missed and irregular periods, may be related to fluctuations in the hormones estrogen and progesterone, or low estrogen and progesterone levels. And many of these symptoms could also be related to estrogen dominance, in which estrogen is either high or normal and progesterone is low. Endometriosis, a family or personal history of female cancers, anxiety and panic attacks, heavy and painful periods, frequent miscarriages, infertility, fibroids, fibrocystic breasts, and weight gain around the hips and thighs may indicate an estrogen dominance picture. High levels of male sex hormones like testosterone, irregular periods, weight gain, acne, and hair loss may indicate a female hormone condition called PCOS. Fatigue, brain fog, difficulty losing weight, puffiness, constipation, dry skin and hair, and a lower body temperature may be signs of hypothyroidism. And then finally, within the context of this article, symptoms of reactive hypoglycemia, such as feeling dizzy, anxious, and shaky between meals, craving sugar, noticing weight gain on the abdomen, having difficulty losing weight, and having a low morning appetite, but nighttime carbohydrate cravings, combined with binge eating at night, can all be related to insulin resistance or poor blood sugar control. In my naturopathic practice, I see common patterns of symptoms that indicate certain hormonal imbalances. And these patterns often represent vicious cycles where our body is stressed beyond a capacity to balance these interconnected webs of chemical interactions, which causes further imbalance. So, for example, estrogen dominance can actually impair the mechanisms that help move estrogen and detoxify estrogen from our body. And that leads to more estrogen dominance. When we're stuck in these vicious circles, that's where I think naturopathic medicine can step in to help move us back into a state of balance. So before I go on, there's an acronym called PTSD, an unfortunate acronym, to describe all of the ways in which hormones interact with each other and all the ways in which we as functional medical doctors or naturopathic doctors need to look at hormones rather than just looking at absolute levels. So the P stands for production of the hormones in question, right? So is your brain or are the adrenal glands actually making the hormone? Do they have all the ingredients needed, the amino acids or the cholesterol and all of the cofactors, all the vitamins to make these hormones? The second one is the T is transport. So these hormones are bound, like you think of how we travel down highways in cars, some of these hormones are bound on proteins that prevent them from interacting with the tissues en route to the target tissue. We're looking at their distribution and their interactions with other hormones. So insulin and estrogen and the thyroid hormones interact with each other. There's a crosstalk that happens. So all of these hormones know each other. The S stands for the sensitivity of the hormone signal. So maybe you're making enough insulin and your insulin is being transported properly, but the cells that the insulin is trying to talk to are not listening to it. And that would characterize insulin resistance. This can happen to other hormones as well. And the last one is detoxification. So how are we able to actually remove these hormones from our body after we've used them up? And this can be, this can be one of the underlying causes of estrogen dominance, where the body is just not able to pull estrogen out of the system once it's finished using estrogen. But it can also happen to some of our neurotransmitters like dopamine and norepinephrine. If we have slower ability to process and metabolize those hormones, we end up having those hormones circulating in those neurotransmitters circulating in our brains for longer periods of time. And this may happen to you if you are noticing that when you get stressed out or when you get anxious, it's difficult to calm down, even though that thread or that thing that caused you to be anxious in the first place has been removed. And then with dopamine, this can happen where people feel like it's difficult to let go of things. It's difficult to shift their attention or to they might talk about how like they're maybe picking a fight or feeling really irritable, and a witness, like part of their inner witness, is looking at that behavior and Cindy, hi Cindy, and telling them to kind of calm down, but they're sort of locked into this thing that they're doing, this irritability. It's difficult to kind of let go of that mental state and an emotional state that they're in. And this may be a characteristic of just slow dopamine recycling and slow norepinephrine recycling. So let's visit these imbalances in more detail. So first, let's talk about cortisol, one of my favorites. So speaking of stories, here's one I hear often. You wake up in the morning exhausted. Your brain is in a fog, and you don't feel alive until a cold shower or double espresso knock you out of your stupor. Things get better once you get moving, but you wonder why your energy never fully bounces back to the way it was, or the way you remember it being in the past. Like you think to yourself, I used to play sports in university. Now just thinking of sports makes me tired. Is this what getting older feels like? By the way, you're in your 30s. The days at the office stretch on forever, concentration and focus are difficult. You see a coworker, and then you realize in horror you can't bring her name to mind. You've known her for a year. Is it Cynthia, Sylvia? Your brain hurts. In the afternoon, you think longingly of napping, but instead you take your place in the long line for coffee and something carby and sugary like a cookie. When it comes time for sleep, at the end of the day, you're either out like a light, or you find that it's difficult to turn your mind off. You're tired, as always, but you're also wired. Maybe you notice this surge of productivity around 10 p.m. Sleep doesn't feel restful, and you often wake up sleepless at 2 to 4 a.m. in the morning. When your alarm rings a few hours later, the cycle begins again. Cortisol, one of our stress hormones, has a circadian rhythm, which leads to an imbalance producing these circadian-like imbalance patterns. Its levels are highest in the morning in a healthy individual, about an hour after waking. Cortisol promotes energy, alertness, and focus, contrary to what we hear about cortisol being the bad stress hormone. It's also a potent anti-inflammatory hormone. Cortisol is what makes us feel alive in the morning, bouncing out of bed like Shirley Temple and her curls, like full of vim and vigor. Throughout the day, our cortisol levels, though, slowly dwindle unless a major stressor causes them to spike abnormally, or unless we engage in really intense exercise. They're lowest in the evening when melatonin, our sleep hormone, begins to rise, inducing feelings of sleepiness and preparing us for a night of rest. Our modern day world, however, calls on cortisol to perform maybe more than its fair share of work. Cortisol's around when we're hauling ourselves out of bed after an adequate night of rest. Cortisol fuels gym workouts, gets us to our meetings on time, allows us to meet deadlines, tolerates traffic jams, responds kindly to tyrannical bosses, and makes sure that the kids get to all their after-school events. Cortisol is made in the adrenal glands, 2 endocrine glands that are located on the top of each kidney, and it's made in response to signals from the brain that perceive stress in our environments and our bodies. When stress hormones are high, we experience a tired and wired feeling. During this time, we might feel we thrive better under stress. Workouts boost our energy, we have a hard time quieting down, and we rarely feel hungry. We might still struggle with weight gain, however, despite not eating as much as we think, especially on the abdomen and face. So cortisol tends to encourage fat deposition in those areas. We might feel tension, tight muscles in shoulders, and body pain as muscles clench up, preparing to fight or flee. And this happens because one of the effects of cortisol is to dump magnesium, a muscle relaxing mineral, from our system, encourage muscle contraction. Chronic stress is associated with high levels of cortisol, so we work long hours, late into the night, we go. This may give us a high, or it may feel exhausting and depleting, depending on the health of our hypothalamic pituitary adrenal axis. Many of us can exist in this state for months or even years. Sometimes a compounded stressor, such as a divorce, an accident, or a loss, can tip us over the edge into a depleted, burnt-out state. If we think of our stress capacity like a bucket, when we're adding, when our bucket is already half full with just the daily things that we have to get done in a day, and then we add more to that bucket, it can tip the scales and throw us into a burnout. Burnout, often following a period of prolonged stress, can be associated with low cortisol signaling. Our bodies have simply stopped being able to produce the stress hormone necessary to meet the needs of our daily lives. And also glucocorticoid receptors, which respond to cortisol and that are located in the brain and in the cells of our body, sometimes can stop responding to cortisol. So just as a cell can become insulin resistant, cells can also become cortisol resistant. Too much or even too little, and I'll explain that later, of a hormone can cause cells to start ignoring their signaling, resulting in symptoms of low levels of the hormone in some areas of the body, but high levels in others. Cortisol is a really complicated molecule, so it both encourages the stress response, but it also turns off the stress response when levels reach a certain point. And it turns off the stress response in our brain and in our pituitary gland, and also in the corticoid receptors. So our stress response is very tightly regulated by the body. So often it's actually that cortisol levels are too low that results in an impaired stress response. This prevents our fight or flight system from properly shutting off. So there's not enough cortisol in the system to shut off the fight or flight response. This is a paradox, but this is sort of how our hormones work. So cortisol resistance can then ensue, and this can lead to further stress hormone disruption. And the result of an imbalance in cortisol, otherwise termed the hypothalamic pituitary adrenal, from now on I'm just going to call it the HPA axis, dysregulation, is weight gain and fatigue and brain fog. Inflammation, because cortisol is anti-inflammatory, but when we don't have enough acting on tissues, inflammation arises. And immune system activation, digestive issues, restlessness, impaired sleep, decreased cognitive function, and mental health conditions such as anxiety and depression. There is glucocorticoid resistance found in the brains of people with depression, anxiety, and other mental health conditions such as bipolar and OCD. And this may be causing inflammation in the brain that's leading to these mental and emotional and behavioral symptoms. When cortisol levels are low, the body makes adrenaline and noradrenaline, or epinephrine and norepinephrine, to meet our needs, to keep us alert and functioning and responding to stress. This often leads us to feel anxious and shaky and nervous, contributing to those classic anxiety symptoms. Cortisol also influences the function of our sex hormones, our thyroid hormones, and blood sugar. Imbalances in any of these hormonal systems can be a result of an impaired HPA axis. So when we're talking about these other imbalance patterns, we're going to always kind of bring it back to cortisol because we're also looking for what is the root cause. And cortisol imbalance in itself is still not a root cause because we want to understand what environmental, psychological, and emotional factors are contributing to this hypersecretion of cortisol, or this resistance in cortisol signaling. So when it comes to cortisol testing, the two main ways to assess the body's level of cortisol are through serum, blood tests, and saliva. You can also do urinary cortisol testing. A study found that both of these tests were equal when it came to diagnosing Cushing's disease, which is a condition of highly elevated cortisol. One of the advantages to salivary cortisol testing, however, though, is the ability to obtain multiple samples in one day, and that way you can look at someone's cortisol curve. And the cortisol curve is what I described earlier, where cortisol is high in the morning and then it drops throughout the day. The cortisol curve is measured by assessing 4 samples of salivary cortisol, taken at 4 key points during the course of one day. It measures free cortisol, however, which may only represent about 5% of the total cortisol in the body. Free cortisol is just the cortisol that's free flowing through our saliva and our blood, whereas bound cortisol is being transported to other tissues. When salivary cortisol levels can be, salivary cortisol levels can be a good starting point for assessing the cortisol curve, but they don't tell us everything about the health of the glucocorticoid receptors or the HPA axis system as a whole. So remember the acronym PTSD. So we're looking at just the levels of cortisol, but we don't understand how it's being produced or how it's being transported or how it's being, the sensitivity of the cells, or even how it's being detoxified from the body. All we know is the amounts that are floating around. So, for example, high cortisol levels may be seen in patients who are actually experiencing low cortisol signaling, such as depression and anxiety and chronic fatigue. Errors in obtaining salivary cortisol samples, such as not taking samples at the right time, can lead to falsely low cortisol readings. In my opinion, this makes symptoms and health history the most valuable tools for properly assessing HPA axis function. Cortisol and melatonin. Melatonin, our sleep hormone, also operates on a circadian rhythm. It's released by the pineal gland in the brain and induces sleep. Its release corresponds to a drop in cortisol levels at the end of the day. That release is impeded by artificial light exposure at night, lack of daytime sun exposure, alcohol, stress, and HPA axis disruption, among other lifestyle and environmental factors. Melatonin, like other hormones, can be tested for in blood, urine, and saliva, but I find more value in assessing sleep quality and quantity by taking a thorough health history while also restoring a patient's sleep hygiene and HPA axis regulation. Many patients with sleep issues can benefit from a trial of supplemental melatonin to see if that helps their sleep. And I often recommend taking it 2 to 3 hours before bedtime to coincide with the body's natural melatonin surge, and taking a prolonged release version to promote sleep maintenance as 2 strategies that I use for helping patients sleep better. Working on sleep and circadian rhythms is also beneficial for restoring HPA axis functioning, so they work hand in hand. You can help with HPA axis functioning by boosting melatonin function, and you can also boost melatonin function by restoring HPA axis functioning. So next is the female hormones, estrogen and progesterone. So the most prevalent female sex hormones are estrogen and progesterone. These 2 hormones ebb and flow in distinct ways through a woman's monthly cycle. Estrogen creates an M shape, resulting rising at the beginning of the cycle to its first peak around ovulation, halfway through the cycle. At this time, women typically experience their best mood, energy, and motivation in a healthy individual, perhaps noticing a rise in libido as well. After ovulation, estrogen dips a little bit, and then it rises again, peaking about a week before a woman's menstrual cycle is due. After this, estrogen takes a nosedive, dropping down to low levels around the time that menstruation begins. And this is called day 1 of the menstrual cycle, the first day of your flow. Progesterone, on the other hand, is largely absent the first half of the cycle, before ovulation. Then, after ovulation, it begins a steady climb, and it peaks with estrogen, with that second M, about a week before the arrival of the next period. After peaking, just like estrogen, progesterone then takes a dip, and that stimulates the uterine lining to shed, and that causes us to have a period. And that begins day 1 again. So, PMS and PMDD, premenstrual syndrome, and premenstrual dysphoria disorder. My practice is populated by women who experience various forms of grief at different stages of their monthly cycle, being a naturopath that focuses on hormones. Many of my patients experience PMS and the more severe PMDD, premenstrual dysphoric disorder, which is characterized by intense mood swings, irritability, depression, or anxiety, panic attacks, and psychosis in the most severe cases, lasting up to 2 weeks before their periods arrive. The mood changes in PMS and PMDD are associated with fluctuations in estrogen and progesterone, and this can wreak havoc on our brain chemistry because estrogen and progesterone influence our neurotransmitters. So, for example, estrogen has a beneficial effect on mood. It increases dopamine in the brain and serotonin in the brain. Dopamine and serotonin are 2 antidepressant feel-good neurotransmitters. If we don't make enough of them, or we don't have enough of them in circulation in our brain, depression can result. Estrogen also increases something called brain-derived neurotrophic factor, BDNF, and that's a chemical that stimulates the growth of brain cells. So good levels of estrogen can boost our memory, our concentration, and cognition, as well as positively influence mood. Low estrogen conditions like after menopause can result in this feeling of brain fog and impaired memory. Progesterone does other stuff. Progesterone breaks down into a chemical called allopregnenolone. And allopregnenolone acts like another hormone called GABA, which is a calming neurotransmitter in the brain. Bioidentical progesterone therapy, therefore, is often used as a treatment for anxiety and insomnia. When estrogen and progesterone levels surge a week before ovulation, then suddenly drop, this can sometimes cause drastic fluctuations in mood. This can cause cravings for sweets, which can, via other mechanisms, raise serotonin in our brain. It can cause crying, lack of motivation from this drop in dopamine, or severe anxiety that can all occur when hormones drop right before a period is due. However, elevated levels of estrogen and progesterone can also be problematic. Estrogen stimulates dopamine, as I said before, and dopamine is this feel-good hormone, gives us energy and motivation and drive and passion. But however, in genetically vulnerable women who have problems recycling dopamine, so clearing dopamine from their brains, elevated levels of dopamine can also cause excess irritability, low stress tolerance, and even mania or psychosis. That difficulty letting go of certain thought processes or emotions can step in here. Estrogen also slows the recycling of stress hormones, epinephrine and norepinephrine, particularly norepinephrine. And this can lead to symptoms of acute stress and anxiety if our estrogen is dysregulated. This means the dramatic rises and falls in estrogen throughout a woman's cycle can cause her to feel irritable and anxious one week and unmotivated and depressed the next. Smoothing our hormonal ups and downs can be a key factor in regulating a woman's menstrual cycles and soothing her mood and emotions throughout the month. See how complicated this stuff is? Perimenopause and menopause. So perimenopause is characterized by declining production of the ovarian hormones estrogen and progesterone. Estrogen tends to rise and fall dramatically throughout a woman's remaining cycles as they're entering menopause, while progesterone levels tend to stay low because progesterone levels rise after ovulation. So if you're no longer ovulating, you're no longer making as much progesterone. The result of these changes are symptoms like hot flashes, night sweats, brain fog, fatigue, and depression when estrogen levels suddenly tank, and increased stress and anxiety when estrogen levels abruptly spike. During this time, cycles may become irregular. Some of my patients comment that their periods are incredibly light one month, and then they're like, oh, okay, it's happening. I'm not going to have my period anymore. And then all of a sudden they get the heaviest period of their lives. Some patients get periods every few months as they slowly decrease in frequency, and others notice increased frequency, spotting between cycles, or even a full-blown period every 2 weeks in more extreme cases. Weight gain tends to drift from the thighs and buttocks to the abdomen, and so once pear and hourglass-shaped figures begin to resemble apples. Fatigue is also a common symptom. Women may experience poor sleep due to night sweats from estrogen deficiency, and anxiety from insufficient progesterone. So what a joy, right? And many of these perimenopausal symptoms are a relatively modern phenomenon, however, and these imbalances and these ups and downs can stem from a dysregulated HPA axis. So cortisol and stress lie sometimes even further down the tree to the roots of these patterns. After cessation of periods, it's the job of the adrenal glands to take over sex hormone production. However, if the HPA system is preoccupied with organizing a stress response, this can affect the production of other hormones. Impaired estrogen clearance is another root cause. So many women struggle with symptoms that are related to relatively high levels of estrogen, often caused by impaired estrogen clearance. That's the D in PTSD, the detoxification. These conditions can include heavy and painful periods, fibrocystic breasts, or conditions like fibroids and endometriosis. Chronically elevated estrogen levels also include a risk of certain hormone-associated cancers such as breast cancer. These women may experience irritability and anxiety through estrogen's interactions with stress hormones and also from a relative deficiency in progesterone. A relatively high level of estrogens compared to progesterone is termed estrogen dominance. Estrogen is normally cleared through the digestive system, the liver, and the intestines. So first, the liver neutralizes estrogen and the intestines release it from the body. A sluggish and congested liver, therefore, causing a slower rate of hormonal clearance. So think of it like a clogged drain that just can't, drain stuff anymore or as efficiently. An increase in environmental toxin exposure or an overconsumption of alcohol or other things that slow down liver function can slow the liver's ability to regulate estrogen levels in the body. Constipation and a dysbiotic gut can also impair estrogen clearance. Our gut bacteria actually turn off estrogen. And if we have an imbalance in our gut bacteria, estrogen gets turned back on and reabsorbed into circulation. So symptoms of estrogen dominance include stubborn weight gain, typically around the hips and thighs, heavy and painful periods, tender and painful breasts, fibrocystic breasts, endometriosis, uterine fibroids, acne, cyclical mood swings, especially premenstrual anxiety and panic attacks, and irregular menstrual cycles. Low progesterone. So aside from impaired estrogen clearance, another pattern of estrogen dominance or another cause of estrogen dominance is low progesterone. So in this case, estrogen levels in a woman's body a week before her period is expected are normal or even low, as in the case of menopausal or perimenopausal women. So they have lower estrogen sometimes. However, an even lower progesterone level still results in a pattern of relative estrogen dominance. This can cause some of the same symptoms as excess estrogen: anxiety, irritability, heavy and painful periods, weight gain, PMS, fibroids, fibrocystic breasts, and so on. Low progesterone, however, can also be a culprit in unexplained fertility or early term miscarriage, because one of the jobs of progesterone is to maintain the uterine lining in pregnancy. Progesterone is released from the ovaries after ovulation. So a lack of ovulation is a primary reason for low progesterone levels. Anovulatory cycles can occur in women with polycystic ovarian syndrome, women with high levels of physical and emotional stress that shut off hormone production and signaling, or women entering menopause. Some progesterone, however, is also made in the adrenal glands. So it can eventually be progesterone can eventually be turned into cortisol, aldosterone, which is a steroid hormone that is involved in saltwater balance in the body, and androstenedione, which is a male sex hormone that then goes to make testosterone and then estrogen. So women with high cortisol demands due to chronic stress may actually be shunting their progesterone made in the adrenal glands to produce the hormones to support the stress response. Not only can stress alter ovulation and fertility through various other mechanisms, it can also rob the body of progesterone, directing any progesterone made towards cortisol production. And that's the P in the PTSD, is the production of hormones. So progesterone production can be faulty from these other root cause symptoms or root cause situations. Testing estrogen and progesterone. So you can test estrogen and progesterone just like cortisol in saliva, urine, and blood. Month-long salivary hormone testing of estrogen and progesterone can be an easy and effective way to track the ebb and flow of these hormones throughout a woman's monthly cycle. So in this test, women obtain a salivary sample every 3 to 5 days in the morning for the duration of the month to track how their estrogen levels correspond with progesterone and how both hormones rise and fall. In my practice, however, I often start by running blood tests for a cost perspective. So I test hormones usually on day 21 of a 28-day cycle to coincide with the peak of progesterone and estrogen. This can help us calculate the progesterone to estrogen ratio and establish whether the cause of estrogen dominant symptoms are high estrogen or low progesterone or both. Blood tests offer the option of looking at estrone as well, which is a more problematic form of estrogen, as well as estradiol, which is the most common metabolically active estrogen in the body. Sometimes I find that estrogen is normal, progesterone is normal, and then estrone comes after we've ordered that, and that's abnormally high. And that's even more problematic than just a typical estrogen dominance involving estradiol. In the blood, we can also look at LH and FSH, which are two hormones produced in the brain and the ovaries that orchestrate ovulation. FSH tends to be high in women in menopause or perimenopause, while LH tends to be elevated in women with polycystic ovarian syndrome. And both of those can be lowered in women who are not ovulating due to stress or lack of body fat or overexercise. Dried urinary metabolite testing, or DUTCH, DUTCH testing, is an effective way to understand how hormones are broken down and processed by the body. Looking at the entire hormone breakdown pathway provides a more in-depth look at the complexity of hormones in a woman's cycle, and it can guide treatment in specific, useful ways. Now we'll look at the male hormones. So, for example, testosterone. And all of these hormones, the male-female hormones, are present in male and female bodies, just in different amounts. So, polycystic ovarian syndrome, PCOS, is one of the most common causes of infertility and the most common endocrine disorder in women of reproductive age. It affects about 10% of menstruating women. So 1 in 10. PCOS is a collection of various symptoms and complex hormonal causes. That's why it's a syndrome, not a disease or disorder. However, most cases of PCOS, the whole umbrella of PCOS comprises missed periods in ovulation, male pattern facial hair growth, especially on the upper lip, chin, breast, and abdomen. And I have Frida Kahlo here to signify that, and the presence of cysts on the ovaries. Other common symptoms of PCOS are weight gain, estrogen dominance, male pattern hair loss, so hair loss on the crown of the head, insulin resistance, infertility and acne, especially the hormonal cystic acne on the jawline. PCOS is characterized by elevated levels of testosterone, a male sex hormone, or other androgens on blood work. Acne, weight gain, infertility, and hair loss are the main symptoms that bring women with PCOS into my office. PCOS is a complex process that involves an overproduction of testosterone in the ovaries, coupled with insulin resistance. Therefore, when we're treating it, we're looking at balancing blood sugar through diet and lifestyle, and that can have a major impact on symptoms. The conventional treatment for missed or absent periods is oral contraceptives, which of course don't treat the underlying cause of anovulation. Oral contraceptives prevent ovulation. That's the whole point of them. We don't want to get pregnant. We don't want to ovulate when we're on them. That's why women with PCOS often seek naturopathic and functional medicine solutions to treat the root cause. So when it comes to testing for PCOS, I often test blood for estradiol and progesterone on day 21 of a woman's cycle. A very low progesterone level may indicate that this woman is not ovulating that cycle. And I'll also test LH and FSH. So a high LH to FSH ratio can be indicative of PCOS, even if cysts are not present on an ovarian ultrasound. Other important tests that are often ordered are free testosterone, or DHEAS, which is another male hormone made in the adrenal glands. Glucose control and insulin resistance can be assessed by looking at fasting blood glucose, fasting insulin, and HbA1c. HbA1c is a marker that looks at long-term glucose control. Prolactin, which is another hormone released by the pituitary gland, can sometimes be elevated in anovulatory women with PCOS. And a 4-point salivary cortisol test may be useful in women with PCOS who are experiencing symptoms of cortisol dysregulation, which can contribute to insulin resistance, but also affect ovulation and hormone regulation, particularly progesterone production. So sometimes the root cause of PCOS is insulin resistance, sometimes it's an overproduction of male sex hormones, and sometimes it can be HPA axis dysregulation. Prolactin is a hormone released by the pituitary glands to promote milk production after a woman gives birth. However, some women will have elevated levels of prolactin in blood despite not being currently pregnant or breastfeeding. And so that's called hyperprolactinemia, which is elevated prolactin and can be a cause of anovulation. It can mimic some symptoms of PCOS and menopause, including hot flashes, absent or regular periods, infertility, and even the release of milk, like a milky discharge from the breast, even when you're not currently lactating. Hyperprolactinemia may be caused by low-calorie diets, liver issues, hypothyroidism, and issues with the pituitary gland itself, such as a pituitary tumor. Prolactin can be tested in blood, and if levels are elevated, an MRI should be conducted to rule out a physical issue with the pituitary gland, such as a pituitary tumor. An herb called vitex, chase tree or chaseberry, other names for that same herb, actually it works by lowering prolactin levels. So if we find elevated prolactin, that may suggest that chase tree could be helpful. Oxytocin is a hormone produced in the brain and secreted by the pituitary. It aids in childbirth. It's also termed the love hormone, so it's associated with feelings of intimacy and connection. And so high and low levels of blood oxytocin can be possible in men and women who are not pregnant or breastfeeding, but we don't fully know the clinical applications of testing for this hormone and treating it. Now onto our thyroid hormones. So the thyroid is a butterfly-shaped gland on our neck, right below our Adam's apple. It's the master thermostat of the body. It controls heat and metabolism. It pumps out thyroid hormones, T4 and T3, which tell cells to burn fuel, creating energy and heat. Because our thyroid hormones interact with the cells in every body system, symptoms of hypothyroidism or low thyroid hormone function can be incredibly diverse. So common symptoms of hypothyroidism are weight gain or an inability to lose weight, fatigue and sluggishness, brain fog, hair loss, low body temperature, constipation, dry skin and hair, puffiness, infertility, and altered menstrual cycles, such as missed periods or heavy periods. And aside from autoimmunity, other causes of low thyroid function can be HPA axis dysregulation and chronic stress, a very low calorie or very low carbohydrate diet, sudden weight loss, a deficiency in nutrients needed for thyroid function such as iron, zinc, iodine, and selenium, and a body burden of environmental toxins such as heavy metals like mercury. So when it comes to testing for thyroid function, Conventional doctors will often just test something called thyroid stimulating hormone, or TSH. And that's the first thing I will also check before getting deeper into assessing a thyroid panel. So TSH is not a thyroid hormone. It's a hormone made in the brain, and it urges the thyroid to pump out the actual thyroid hormones, T3 and T4. It gives us doctors an indirect measure of thyroid regulation. So if our TSH levels are high, this suggests that thyroid function is sluggish. The brain needs to send a louder signal to get an unresponsive thyroid to work. I heard someone use an analogy of like when you're screaming at your kids to pick up their clothes on the floor. If they're not listening, if they're hypoactive, then the signal or the yelling has to increase in frequency and increase in volume. However, TSH is only a periphery marker of total thyroid function, so it doesn't give us the whole picture. It also ranges on conventional lab tests, and those ranges may fail to pick up some cases of subclinical hypothyroidism or impending cases of autoimmune thyroid conditions, which are otherwise termed Hashimoto's thyroiditis, and that is the most common cause of hypothyroidism, affecting about 80% of cases. So, to properly assess someone's thyroid function with symptoms of thyroid dysregulation or hypothyroidism, a slightly elevated TSH or a family history of Hashimoto's, I'll then order a thyroid panel. This is a blood test that measures TSH, but it also looks at free thyroid hormones, so free T3 and free T4. I also assess for autoimmune thyroid conditions by testing for two antibodies, antithyroglobulin antibody and antithyroperoxidase antibody. And both of these antibodies, if they're elevated, may suggest the presence of an autoimmune thyroid condition when taken into context of the entire thyroid panel and a patient's symptoms. Insulin. So some of the most common hormonal dysfunctions I see in my practice are insulin resistance and reactive hypoglycemia or blood sugar imbalance. And insulin dysregulation can often lie at the root of a lot of people's hormonal imbalance symptoms. These issues often lie at the heart of other hormonal imbalance patterns, such as irregular menstrual cycles or HP axis dysregulation. So when we eat, glucose enters our bloodstream. It provides fuel for our cells. Insulin helps our cells access the hormone, glucose, and it spikes after each high carbohydrate meal. The higher the meal is in the glycemic index, so the more the sugar or refined carbohydrate it contains, and the higher the ability of it to spike our blood sugar, the higher our post-meal blood sugar and insulin spikes will be. And so without insulin, we'd slowly lose energy and die, unable to get glucose into our cells and make energy. Individuals with type 1 diabetes can't make their own insulin, and they must inject it daily to keep their cells fueled and their blood sugar stable. For those of us who do make insulin, however, large blood sugar spikes after a meal can be problematic. Insulin is a storage hormone. It helps energy get into cells, and it helps build muscle and brain cells, but it also blocks the breakdown of fat cells, so it can block weight loss. Insulin also drives down blood sugar levels. So when blood sugar rises too quickly after a meal, a large insulin response can drop blood sugar levels too drastically, causing reactive hypoglycemia or feeling hangry. So hungry, angry, irritable, tired, lightheaded, weak, and dizzy in between meals. Individuals who experience hypoglycemia feel shaky, irritable, dizzy, and anxious between meals, and they often suffer from anxiety and panic attacks and feel hungrier at night. I see a lot of reactive hypoglycemia in my patients with anxiety and emotional lability. So patients with reactive hypoglycemia may wake up in the middle of the night as their bodies are able to go 8 hours, the length of a decent night's sleep, without food. So they'll wake up restless and perhaps anxious in the early hours of the morning. And they don't always feel hungry or crave food at this time. Paradoxically, the same individuals rarely feel hungry at breakfast time, may even feel nauseous on waking in the morning. So I often see anxious patients wake from a restless sleep and toss back only a coffee in the morning, skipping breakfast due to slight morning nausea or just not feeling hungry at all. Then at 10 a.m., feeling ravenous and shaky, they might scarf down a high glycemic bagel, croissant, or muffin. Classic. Later on, they'll enjoy a light lunch, maybe a sandwich, often feeling foggy and lightheaded after eating it. At 2 to 4 p.m., they may feel like an afternoon nap, instead indulging in a coffee and a sweet treat to buy them energy for the remaining hours of the day. Finally, after enjoying a large dinner, like a proper meal at the end of the day, once they get home, they find themselves snacking all night long. Their bodies are finally urging them to ingest the nutrients they were lacking throughout the day. Then they fall into bed feeling full, restless, and tired, and wired, and the cycle begins again. And when our blood sugar falls, we not only feel hangry, weak, and crave processed carbs, but our HPA axis also gets stimulated. Cortisol is a glucocorticoid, so it helps our body control blood sugar. It brings it into the normal range after insulin sends it tanking too low. Low blood sugar is a stress signal, a stress trigger. This drop in blood sugar, therefore, needlessly triggers a stress response from the adrenal glands, which can further worsen anxiety, HPA axis disruption, and glucocorticoid resistance. When blood sugar and insulin are spiked repeatedly for days, months, and years on end, cells can stop responding to insulin's signal, like our response to the pesky telemarketer. Cells eventually stop picking up the phone when insulin calls. However, our cells still need insulin, so more and more insulin must be released to trigger the same response from insulin-resistant cells. This makes cells even more resistant as they require even more insulin release the next time blood sugar rises to get glucose into the cell for fuel. And so the cycle becomes vicious. Elevated insulin levels can also cause inflammation, fat gain, fatigue, depression, reactive hypoglycemia, and HPA axis dysregulation. The more resistant our cells become to insulin, the more cortisol must be called on to maintain blood sugar levels, and this also sets us up for glucocorticoid resistance. PCOS is also characterized by higher levels of fasting insulin. This prevents ovulation, which causes infertility and female hormone imbalance. When insulin resistance persists, type 2 diabetes, where the body is no longer able to keep blood sugar in a safe range, develops. So the body is no longer responding to insulin very well, and blood sugar tends to be elevated, especially after a meal, but also while fasting. Type 2 diabetes is characterized by chronically high blood sugar, which poses a danger to our small blood vessels, the blood vessels in our eyes and our kidneys, and it's also a potent inflammatory condition. It increases our risk of heart disease and elevated insulin. It also increases our risk of non-alcoholic fatty liver disease. It affects almost 10% of the adult population. It's the 7th leading underlying cause of death in North America, costing $350 billion a year to manage in the United States alone. And type 2 diabetes is largely a condition of lifestyle. Insulin-related weight gain can also affect female hormones. Fat cells make estrogen in the body, and that can lead to estrogen dominance. Insulin also interacts with a hormone called leptin, and this is created by fat cells in response to calorie intake. When body fat levels get too high, cells can become leptin resistant. The body no longer senses dietary calorie intake, leading to increased hunger, and this can exacerbate the problem of weight gain and insulin resistance because it causes you to eat more before you feel full. So when it comes to testing for insulin resistance, when I meet a patient who is presenting with stubborn weight gain, estrogen dominance, and stress, I will often assess their blood for insulin resistance, and I'll look at blood levels of fasting insulin and fasting glucose in order to do this. So between these two values, fasting insulin and fasting blood glucose, I'll do a calculation called HOMA-IR, HOMA-IR. This can give us a baseline measure of how well the body is compensating to control blood glucose. Just like estrogen and progesterone interact and need to be assessed relatively, so do insulin and glucose. So elevated fasting glucose can indicate if you're diabetic, but if your body is still keeping glucose in a normal range, but it's using a lot of insulin to do that, that may result in diabetes down the line, maybe 20 years later. So by looking at insulin resistance through HOMA-IR, we can actually detect impending insulin resistance early. I also run HbA1c, and that looks at glucose levels over 3 months. And I'll often run a cholesterol panel and look at inflammatory markers such as C-reactive protein. Insulin resistance will put all of our hormones on a roller coaster. This becomes very difficult to get off unless we prioritize the diet and lifestyle interventions that address blood sugar control. And it can be reversed, it can be healed, but it takes a bit of dedication and a bit of work. Assessing hormones. So when presented with a patient suffering from a complicated symptom pattern, I begin by taking a thorough health history in which we investigate energy levels, sleep quality and quantity, mood and mental health history, period health history, such as when your first menstrual period came on, what it was like when you were a teenager, if you ever went on birth control, what it's like now, how often you get your period, if it comes regularly, how heavy it is, how painful it is, and if you get any PMS symptoms. I'll look at your family history. Does your family have any history of endometriosis, fibroids, female cancers, autoimmune thyroid issues, diabetes? I'll look at your dietary intake and exercise. So what do you eat in a typical day? Usually I have people fill out a diet diary to do this more accurately. How often do you exercise? What kind of exercise do you do and for how long? I'll also look at health risk factors like smoking, alcohol use, and past health history, as well as social factors, what you do for work, what you do for your hobbies, who the people are in your life, where you live, environmental toxin exposures, etc. This takes about 90 minutes. Depending on how clear the patient's symptom picture presents, we may opt to make some changes before testing to gauge the body's response to an increase in nutrient intake. So sometimes we'll just start off with a couple of recommendations, and then on the second visit or the third visit, if necessary, we'll order a more comprehensive blood work or a more focused blood work. And this totally depends on cost and finances and how collaborative a patient's medical doctor might be. Blood testing might include a thyroid hormone panel, an in-depth look at female hormones, fasting insulin and fasting blood glucose, and other markers that can help us assess health, such as cholesterol and inflammatory markers or nutrient levels. And this depends on what someone had tested in the last year already with their family physician. Patients requiring more comprehensive views of their cycles may opt for these other tests I mentioned, such as month-long salivary testing of estrogen and progesterone, or 4-point cortisol salivary testing, or even a dried urine test that looks at hormonal breakdown in the body. And of course, these tests are fairly costly, so cost is a big factor in this, although they're very useful. They provide a lot of useful information. So, for example, here's a sample case. So Jenny, name change for privacy, so this person is not called Jenny, came to me feeling fatigued and anxious. She suffered from anxiety periodically as a teen, but now at age 46, she was experiencing bi-monthly panic attacks that seemed to occur cyclically. The panic would come around ovulation, and then it would also come back premenstrually. It was hard to tell, however, because Jenny also claimed that her periods were all over the place. 1 month they were heavy and painful, causing her to take time off work, crouched on the bathroom floor in agony, and resulting in an naproxen prescription. Other months she barely noticed them, experiencing some light spotting, if anything at all. Very troubling to her was her major mood volatility, which she described like a switch that would suddenly flip on or off, causing her to break down at work or pick fights with her family. Then, almost as suddenly, the cloud would lift and she'd be her cheerful, friendly, loving self again. It was maddening, both to her and those living with her during those dark times, she said. She also noticed disrupted sleep and weight gain around the abdomen, which seemed to ignore her intense workouts and strict dietary regime. She was very highly accomplished at a high-pressure job and commented that she thrived on being busy and was very achievement-oriented and a self-described perfectionist. So, after taking a history, I tested Jenny's blood for estradiol, estrone, progesterone, LH, and FSH levels, all 1 week before her next expected period. I had her fill out a weekly diet diary, so a 2-week-long diet diary, and give her some recommendations about sleep and supplement intake to start with. So when her blood test came back, it revealed elevated FSH, which is indicative of impending menopause. So FSH encourages the ovaries to ovulate, just like TSH encourages the thyroid gland to make thyroid hormone. So same thing. FSH is yelling at the ovaries to start acting, but the ovaries are no longer responding because the body menses are ending. She also had low estradiol and low progesterone. But then she had elevated levels of estrone, which is the more problematic of the estrogens, the one that's most associated with cancer and these toxic estrogen symptoms. So according to her labs and her history, I believe that she was experiencing estrogen dominance and perimenopause, and this was a result of, and the picture that she presented with was a high estrone kind of estrogen dominance. So many of her symptoms were stemming from elevated estrone, low progesterone, and a disrupted HPA axis. We didn't test for cortisol, but we could figure that out based on her symptoms and just how stressed out she was. So together we worked on her diet to provide her body with the nutrients she needed to make the hormones, and to support her brain, mood, and adrenal glands. And by hormones, I mean helping her body make progesterone, helping her body make cortisol, and helping her body make estradiol. We also used herbs and dietary nutrients to promote liver estrogen clearance and to support Jenny's adrenal glands. We addressed the stress in her life, encouraging relaxation, and made sure her body was supported in its ability to make and respond to cortisol. After a few months, Jenny reported a reduction in hot flashes, better sleep, and feeling calmer. She had a reduction in her waistline and better energy and mood. So our hormones, when they're in balance, can cause these vicious cycles in the body that trap us in a state of worsening imbalance. So it's important that we correctly assess these common hormonal patterns through a health history and appropriate testing, and then make diet, lifestyle, and supplement suggestions to address at stopping these cycles. So by doing this, naturopathic doctors can address underlying hormonal issues that might be causing these complex and troublesome patterns of symptoms and hormone disruptions. So thank you guys for listening. This is going to be available on YouTube and Facebook. And my name is Dr. Talia Marcajani. I'm a naturopathic doctor, and I focus on mental health and hormones in my Toronto practice. Have a good day.